And thyrotoxicosis is a state of thyroid hormone excess. So it's also a condition of hyperthyroidism, where hyperthyroidism, the basic difference between thyrotoxicosis and hyperthyroidism is in hyperthyroidism it is a state of excessive thyroid function, whereas in the case of thyrotoxicosis it's a case of excessive thyroid hormone concentration. So thyrotoxicosis can also be caused by hyperthyroidism due to Graves' disease, toxic multinodular goiter, toxic adenoma, iodine overdose, TSH secreting pituitary adenoma, chorionic gonadotropin secreting tumors. Thyrotoxicosis can also be caused by hypothyroidism, which is drug-induced thyroiditis and subacute thyroiditis. So, what are the clinical types of thyrotoxicosis? Four different types are present. Primary thyrotoxicosis is called the Graves' disease. Secondary thyrotoxicosis is called the Plummer's disease. And then you have the toxic nodules and rare causes for hyperthyroidism. So, clinical manifestations: hyperactivity, irritability, palpitations, fatigue and weakness, weight loss with increased appetite, diarrhea, polyuria, oligomenorrhea with loss of libido. Other signs are tachycardia, atrial fibrillation, tremors, goiter, warm moist skin, muscle weakness, proximal myopathy, bladder retraction, and severe cardiomyopathy. So this is Graves' disease, and in Graves' disease you have diffuse vascular goiter. Symptoms appears together with goiter, and this is one figure where you can see that the eye is protruding out. So this is one of the symptoms that you can easily identify Graves' disease. And the TSHR receptor antibodies are present, causing hypertrophy and hyperplasia of the thyroid tissue. Treatment is use of antithyroid drugs or reduce the amount of thyroid tissue by thyroidectomy. So this is the system where you can see that the genetic clone lacks suppressor T cells, and the T helper cells will multiply, and B cells produce TSH receptor antibodies. So the TSH receptor antibodies bind to TSH receptors, and as a result, there is an increase in production of T3 and T4, which clinically presents as hypothyroidism. And this activates pituitary gland, which produces lesser TSH. And second condition, the TSH receptor antibodies bind to TSH receptors in retroorbital connective tissue, and the T cells produce inflammatory cytokines, which increases glycosaminoglycans, causing swelling in the muscle and connective tissues behind the eyes. As a result, it causes ophthalmopathy. So, thyroid storm is a term that is indicated in thyroid diseases, where it manifests as a complication of the hypothyroidism with a mortality of 10 to 75%, and it's common in uncontrolled Graves' disease. Clinical diagnosis is acute disruption of normal steady state of circulating hormones. Precipitating factors include infection, withdrawal of ATD, surgery, trauma, hypoglycemia, burns, iodinated contrast dyes, etc. Clinical features involve fever, tachycardia, this is most common, and other central cardiovascular. So, toxic nodular goiter, it's a long-standing nodular goiter. You can see it in middle-aged women, frequently associated with Alzheimer's, and the internodular tissue is the active region. And rarely it can become autonomous nodule. So, the overactive nodule part of generalized nodularity or true toxic adenoma, and it's not related to TSH receptor antibodies. Normal thyroid tissue is suppressed and inactive. So, clinical features of hypothyroidism: intolerance to heat, fine straight hair, bulging eyes, facial flushing, enlarged thyroid, tachycardia, increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, localized edema, menstrual changes or even amenorrhea, increased diarrhea, tremors, and finger clubbing. So we will compare the features of primary and secondary thyrotoxicosis. Considering the goiter, in primary thyrotoxicosis, firm, diffuse vascular goiter can be seen, whereas in secondary thyrotoxicosis, hyperthyroidism severe in primary, not severe in secondary. Cardiovascular system or cardiovascular symptoms are rare in primary thyrotoxicosis, whereas it's most severe in secondary thyrotoxicosis. Ophthalmic features are more common in primary thyrotoxicosis, whereas lid lag and spasm is seen more in secondary thyrotoxicosis. So, what are the cardiovascular symptoms that are involved? That is multiple extrasystoles, paroxysmal atrial fibrillations, atrial tachycardia. These are the most commonly seen cardiovascular symptoms. Eye signs includes lid spasm, that is sympathetic overactivity, exophthalmos, where your eyes will protrude out, autoimmune etiology, that is glycosaminoglycan deposition, weakness of the extraocular muscle, papilloedema, and corneal ulcers. So, treatment of malignant exophthalmos, control of hyperthyroidism, sleeping proper position, lateral tarsography, prednisone can be used as a treatment. Intraorbital steroid should be avoided. Thyroid ablation with radioactive iodine versus the malignant exophthalmos, and you can also provide orbital decompression. Thyrodermopathy is where hyaluronic acid deposition occurs in the dermis and subcutaneous tissues, and the treatment is topical steroids. Diagnosis of thyrotoxicosis through clinical features, biochemical investigation, thyroid antibodies, and thyroid scan. So, based on the T3, T4, and TSH system, difference would be in T4, where in hypothyroidism T4 is increased, whereas thyrotoxicosis T4 will remain normal. So, these are the thyrotrophy pictures in each conditions, like this is for normal, this is for Graves' disease, toxic multinodular goiter, and toxic adenomas. Antithyroid drugs, carbimazole and propylthiouracil, beta blockers like propranolol and nadolol. Irides can reduce vascularity, and it's also important in a preoperative scenario. Again, you cannot cure toxic nodules. So these are the different thyroid diseases and their treatment strategies. Thank you.